So I'm just trying to orient you to where non-epileptic seizures fall within the greater context in the DSM, since most of you, I don't think, are behavioral health clinicians. So the bigger topic is somatic symptom and related disorders, and within that, there's somatic symptom disorders is you have multiple somatic symptoms without an underlying physiologic cause. Then there's illness anxiety disorder, which is what we used to call hypochondriasis. We're trying to find, as you can see, kinder words to describe things so that patients don't feel as blamed for their symptoms. And this is the patients that are kind of constantly worried, researching online all of their symptoms, coming to you, asking questions. I also find clinically that a lot of these patients prefer using supplements over actual pharmacologic medications. And a lot of these patients don't respond to reassurance. So, you get their MRI and it's normal. You get their labs and they're normal. And just no matter what you tell them, they just don't believe you. And then this is where I specialize in is functional neurologic symptom disorders. And non-epileptic seizures is a subset of that. And then the last category is factitious disorder, which is intentionally creating symptoms to get cared for. And then the one thing that's not in here that kind of relates is malingering, which is, intentionally creating symptoms to get a primary gain, which is something like housing or resources of some kind.
Randi, pseudo seizures, would that be another old term for this?
Yeah. So the reason we don't, I think I might get to the next slide on that. It might be a couple down, but yes, I think I'll get to it.
Yep.
So yeah, this is kind of the criteria for functional neurologic symptom disorders. And as you can see, they can literally have any neurologic symptom, and I've seen pretty much all of these, because a lot of times people can have multiple symptoms. Like on average, patients with non-epileptic seizures will have 6 to 7 different functional neurologic symptoms in their life. Okay, we can go to the next slide. So the reason that I use the word non-epileptic seizures is that they've actually done studies on this, and when you use words like psychogenic, patients hear psycho, oh, you think I'm crazy, automatically the trust between the two of you has been broken. A lot of times we have to spend time explaining this to patients, and sometimes they'll call their events something else. We had one guy who called them Frank. Okay, I'll call them Frank if you want to call them Frank. But so we try to stay away from, and unfortunately the literature has not done this yet, but I think we're trying to make a switch to it clinically at least, to not use anything that makes the patient think we think they're lying, faking, or crazy. And so, we mostly use non-epileptic seizures just because that describes exactly what it is. It's a seizure where, in our clinic, they've been hooked up to an electroencephalograph and videoed at the same time. They're having what in their body looks to be a seizure, but there's no abnormal electrical activity. So that's the non-epileptic piece. And so, it's just, we want to call it exactly what it is. And patients, sometimes people call them, in the UK, they use dissociative seizures, although not 100% of patients with non-epileptic seizures dissociate. So in the US, we haven't really adopted that terminology yet. And then functional seizures, some people like that, but then a lot of people are like, well, I'm not functional at all. I can't work, I can't drive, I can't do all these things, so don't call it that, Although they're not usually as forthcoming. I try to encourage them to be. Okay, next slide.
Sorry, there's a little lag.
Oh, that's okay. I have 2 young kids. Try to practice patience. James will tell you not always successful. So what exactly is it? And so, a lot of people still think that the patients are faking their symptoms, and that's not true. The symptoms are created subconsciously or unconsciously, and it's a physical manifestation of some kind of underlying physiologic or emotional distress. They're starting to do some brain imaging studies, finding some pretty interesting things about how different parts of the brain are connected. For instance, like the supplementary motor area, which is motor planning, with the amygdala, which is, a lot having to do with fear. And so, nothing that helps us diagnose patients or anything like that, but they are definitely finding, brain changes. And so I do truly think one day we will find an actual, underlying physiologic cause, but I think it's just going to be more complicated than, oh, that part of your brain is not as big, or that part of your brain is too big, or something more simplistic for diagnosis. The vast majority of patients do dissociate, very vast majority, And a lot of this is connected to trauma and PTSD. In our population, about 60% of the patients have PTSD and 90% have pretty significant trauma, even if they don't meet full criteria. The way I think about it in kind of a broader way is a lot of times in trauma, people don't feel like they can express their needs. And so the body's trying to express needs that they can't express with their words. And it can be especially hard, we'll talk about this more in the trauma-informed care, but to talk to someone about your needs if they're in a higher power position. And in medicine, that's what happens is, we're doctors, we're educated, and we end up being in this power differential that makes them not feel comfortable expressing themselves. And I'm sure you know that there's many patients who maybe express themselves a little too much, too. So yeah, it's really important never to use what we call the F word in the FND world of faking. Like, they are not faking it. And, in the 5 years that I've been doing this and the almost 1,000 patients I've seen, I've maybe seen a handful of cases where I thought there was a component of malingering or factitious disorder. It's pretty rare, but it's pretty rare. Okay, so one thing they've done studies on, and I really love talking about, is that there's a handful of studies showing that if you know how to explain the diagnosis in a compassionate, empathetic way that the patient understands, some of those patients, anywhere from a sixth to a third, stop having events. And those studies were done with like a year follow-up, so I don't know completely long-term, but that's pretty amazing. Like, I don't know of any other diagnoses where you can just like, you have this, okay, better, And it's obviously not that simple, right? The words we use are really important, and a lot of times physicians are frustrated with these patients, and so they don't have the patience to spend the time they need to, or learn how to talk about these diagnoses. But it really is beneficial to you because, and to the patient, because they will get better. A lot of times patients have done a lot of online research, and it's not always good, but some of them are very knowledgeable. So just getting an idea of what they know about it already, how they understand it already, really can help align you with the patient. A big piece of treating any kind of somatic patient is understanding what they've been through in the medical system. And we're going to talk more in trauma-informed care about this too. But what happens is they go and they say, I am suffering, I have pain, I have a symptom, I'm scared. And the doctor's like, no, you don't. And so they feel very invalidated. And then this gets exacerbated by the fact that so many of them have been traumatized, and so they're getting continually invalidated throughout their lives, and now they're going to you trying to seek help and getting invalidated again. And so it's important to be able to validate that experience. I do a lot of this. Like, a lot of what I do is helping patients understand how to interact with doctors, what they need to ask about, what they need to say, sharing feelings that they have about being in appointments, just advocating for themselves. And so a lot of times the NES, is the body's way of just kind of shutting down. A lot of patients will call it like a reset, like, oh, my computer just crashed and I need to reset. Or describing it as a lot of patients, it's like the description of, the brain is the kind of hardware of a computer, right? The wires and the keys and things like that. And then the wiring of the brain is the software, and that's where the problem with non-epileptic seizures is was the communication within the brain and between the brain and the body. About, most of the patients we see are women, 75%, that's pretty consistent internationally across all studies. Probably has to do with, trauma for the most part, of just women experience trauma more. For you all, I thought what would be relevant is that the older age at diagnosis, those patients actually tend to be more male. And a lot of times what I see is, they're developing new or scary medical problems, and they can't cope with that, and the NES develops kind of as a way to be cared for in that setting. I mentioned this earlier, but while I'm very excited about treating these patients, and I'm in a very supported environment with a neurologist, social worker, and we do group therapy, most people do not feel that when they're treating these patients. They feel very isolated and alone, and talking about that frustration you have can really help, especially with other providers that are treating them. And you guys also have multidisciplinary care, so that's really nice that you could have that as well. All right, so we're going to switch to trauma-informed care. Does anyone have specific questions about non-epileptic seizures before we move on to trauma-informed care?
Epileptic drugs, I'm sure they get put on them. Do you recommend you continue them because they're not causing a lot of harm, or do you recommend them try to get them off of them because they're efficient?
question. So on average, it takes a patient with NES 7 years to get a correct diagnosis. So you can imagine what happens in 7 years. They get put on a lot of drugs that don't work, that have really bad side effects, and anti-epileptic drugs for patients with only non-epileptic seizures are not indicated, and you do want to try to get them off. And that is, been studied to be effective. Because sometimes even those side effects, if you improve them, the NES can get better because our bodies aren't feeling so uncomfortable. Times when we do leave them on are, say they got put on Lamictal and they have a comorbid mood disorder, and the Lamictal's been helping with the mood disorder. Well, then we might leave it on for a different reason. So, yeah, that's a good question.
It's a follow-up question.
Yeah.
Imagine a lot of these people, if you get them off, they have a non-epileptic seizure, they go to the ER, they get loaded with Keppra, and then the recommendation for discharge from that, and then we want to, of course, document why we're not following that recommendation for audit purposes. But how do we speak to patients about that without invalidating them, I guess would be my question.
Very, very.
Because the ER is developing tension.
For sure.
Quite understandably.
Yes. And we are working on educating patients around the state, but we have a long way to go. So what I tell the patient is that, I describe the exact difference between epileptic and non-epileptic seizures. So epileptic seizures are when your brain is having abnormal electrical firing, and all the medications used for epilepsy are geared towards decreasing that. So with non-epileptic seizures, that's not happening. So you're taking a medication unnecessarily that likely has side effects, and so you don't need to be on that medicine. If they're on it for a different reason, I explain exactly why. I say someone put you on Lamictal because they needed to augment your sertraline treatment for depression, or because you have bipolar disorder. And a lot of medications in psychiatry and neurology overlap. And so there are a lot of medicines that we use both for mood and for seizures. And so we are leaving you on this medication specifically for your mood and not for your seizures. And it is not going to help with your seizures. Yeah.
So it just seems like there's patients that have both. They have non-epileptic, and I think that, in my clinical experience, that's what you see. You see the non-epileptic, yeah, and so it is really tricky.
It's actually, so when I first started this work, the approximate number of patients with non-epileptic seizures that also had epileptic seizures, they thought was around 20 to 30%. Now we're looking at bigger samples, and it's more around 10 to 15%. So it's still not insignificant. You're right. 10 to 15% of patients with non-epileptic seizures also have epilepsy.
And then they have the psychiatric comorbidities from the trauma.
Right.
So
Yeah, and so in those cases, the most helpful thing to do is make sure that they know the difference between the events. So like in our clinic, it's, they'll have an EEG, and the neurologist meets with them first and says, okay, see this video of yourself? And there's no electrical abnormality. This is a non-epileptic seizure. Do you see this video of yourself and what this looks like? And sometimes you have to do this with family members too. This is what your epileptic seizure looks like, right? So when you're reporting them to doctors, it's really important to differentiate them because the treatment's so different, right? You don't want to be increasing anti-epileptic medicines for non-epileptic seizures.
and you're doing that in a monitoring unit?
So I'll get to the details of our clinic at the end.
I might wait then, because
Okay.
this is more about diagnosis.
Okay, yeah, we're gonna get to some of that, and then if I don't answer your question. All right, so now on to trauma-informed care. So before we talk about it, we have to talk about what is trauma, and it's interesting because if you were to ask 20 different people, they might give you 20 different answers. And patients have normalized what they've been through so much that sometimes they won't even report it to you unless you give them examples of what trauma is. But generally speaking, it's an event or series of events or set of circumstances that an individual experiences physically or emotionally harmful or life-threatening, which can also be witnessing those events as well. And it has lasting effects, which I'm going to talk about in more detail. It can range from emotional, physical, sexual experiences, life-threatening medical illnesses, which I see quite a bit, any kind of fearing for your life. So if like you're on an airplane and it almost crashed, or something like that, any kind of life-threatening event. And then for those of you who are familiar, and I'll talk about it a little more, the ACE questionnaire, which is Adverse Childhood Events. They also include childhood neglect, having family members with mental health issues or substance use issues, witnessing violence, and poverty. I think, so I'll tell you later that one of the factors of becoming trauma-informed is just to understand how common trauma is. So you guys are already becoming trauma-informed as an organization. In the general population, about a quarter of children have experienced some kind of maltreatment. A quarter of women have experienced domestic violence, and 20% of women have been sexually assaulted in some way. And then, this is just in the general population. So these numbers mostly come from the Kaiser ACE studies, which was done in just a general population of, I think, about 17,000 people. That was not mental health specific. So if you go into mental health populations in psychiatry clinics, substance use clinics, those numbers are even higher. And I know your population has quite a lot of mental health issues, and Leslie told me about 85% of them are some kind of mental health. So looking at adverse childhood events, like why is it important? What are all these adverse effects? So this is what they looked at in the ACE studies. They looked at kind of this hierarchy of these people are dying earlier, they're having more medical problems, they're having more psychiatric problems, they're having pretty much problems in every area of their lives. There's a 10-question piece questionnaire that the studies were done around, and these were the categories that they used: abuse, neglect, and household challenges. And so the results of their study showed that about 60% of the population had at least one adverse childhood event, and then 20% had 3 or more, and it's a dose response. So the more ACEs you have, the more likely you are to struggle with all of these different areas, including more likely to have traumatic brain injuries, mental health problems, substance use, unintended pregnancies, contraction of STDs, STIs, cancer, and so, it's not just mental health, right? People are having physical health manifestations of having experienced trauma. So that's important to know in a healthcare setting. So one of the reasons it's important to learn about this in medical settings, as I kind of alluded to before, is that medical settings can be traumatizing. Not just the power differential, but if you think about what we're doing for patients, right? Kind of gynecologic exams, breast exams, like they're very intrusive. And so it's really important, and sometimes you may trigger a patient not even knowing why. You might look like an abuser, or remind them, or smell like an abuser, something reminds them, and they can feel very triggered in medical settings. So the main components, the main goal of trauma-informed care is to be able to more effectively engage patients in care and improve their outcomes. And so a lot of that requires a lot of open communication. And then the main components are creating safety in the environment, training, which you're doing right now, about what trauma-informed care is, preventing secondary traumatization in staff. So it's a lot of times when you just hear about people's trauma, you can get traumatized by that. And then, being transparent about changes that might happen, and if possible, including patients in the planning process for becoming more trauma-informed. And some of the benefits for using trauma-informed care are that it reduces costs for social services and healthcare. It reduces frequent visits to the ED, and it reduces agitation in the ED as well, when you're listening to patients and trying to understand what they need. So the 3 ways you can do it kind of clinically is patient empowerment, choice, and collaboration. So what does that mean? For me, a lot of times what I'm doing is giving patients as many choices as I possibly can. So, okay, I'm gonna start showing an SSRI. I'm gonna tell you a little bit about Lexapro and a little bit about Zoloft, and let you choose, right? Because to me, it doesn't really matter. There's no difference in efficacy between those two. For a lot of patients who tell me about visits that they have with doctors, sometimes it means, I don't feel comfortable having my gynecologic exam, meeting my PCP for the very first time. Could we push that off until I know you a little bit better? So again, it makes them feel heard, and that their preferences and choices are important to you. Creating an environment of safety and sensitivity. So this can include things like taking, different patient diversity factors into consideration, and that kinds of things that may feel intrusive or may feel traumatic might be different based on their cultural background. And then also, making care settings safe, privacy, making sure, patients feel safe from that perspective too. And then the last thing, is trust and transparency. And so that's just like being really forthcoming with patients, about what you're gonna do, why you need to do it, why it's important, which I'm sure, most people do, but especially for traumatized patients is especially important. So why do these two ideas, non-epileptic seizures and trauma-informed care, connect? So, because patients with non-epileptic seizures and really most somatic symptoms have a higher prevalence of trauma, it's really important to practice these principles with them, because they're more likely to be traumatized. And then, as I talked about before, a lot of people get re-traumatized in the medical system from the experience they've had. Also, in the emergency room, our patients will tell us things like that they've been physically harmed, like the doctor will try to snap them out of their non-epileptic seizures. I've heard, getting sternal rubs, which, may be appropriate if you think someone's unconscious and you're trying to get them back, but in non-epileptic seizure patients, usually it has the opposite effect. Sticking things under their toenails, or like directly telling family members like, oh, they're faking it, just ignore them. Like these things have all like happened to patients over and over again in emergency settings. And so one thing I will talk about is that we want to keep them out of the emergency room if at all possible, which I know is a goal of your guys too. And I kind of talked about that other point, so we'll move on. So treatment. So, the best evidence-based treatment is multidisciplinary. And so the sooner you get people into treatment, the more likely they're to do better. And the sooner you get everybody kind of on the same page, all the treatment providers kind of on the same page. There's good evidence that treating psychiatric comorbidities improves non-epileptic seizures all by itself. So if a patient also has PTSD, also has generalized anxiety disorder, major depressive disorder, treating that can help that NES get better. But psychotherapy and predominantly CBT-based therapy has been the most studied. The CODES trial is the biggest NES trial. Every good trial has to have a good acronym. And that's been the biggest study, basically people trying to kind of gain insight into why the symptoms developed, into what their bodies are trying to express, into their emotional experiences that come along with the event. Sometimes family interventions can be helpful if the symptoms are really especially trying to get needs met by the family. And then the biggest thing you all probably can do is trying to prevent them from going to the ED. So what we do is we tell patients, like, this is what your non-epileptic seizure is. It's not harmful to your brain. It does not hurt your brain the same way epileptic seizures cause kind of slow brain damage over time. So unless you sustain an injury, hit your head, break a bone, do not go to the ED. It usually makes it worse. A lot of times they'll get benzos there, which causes amnesia, and then they're not able to try to understand some of the things associated with the events to then try to decrease them.
About 5 or 6.
Okay. And so iatrogenic harm, these patients actually go to the ICU equivalent to patients with epilepsy, get intubated because people think they're in status. So other options for treatment, individual CBT-based therapy works. There's a workbook that patients can find online to work on by themselves or with a therapist. And then I just, as a provider, try to think, like, what is NES doing in their life? What positive things is it providing? And can we decrease how much positive impact it has and replace it with getting their needs met in other ways? And so responding to events when they happen, a big thing, and it's hard because sometimes you don't know if it's epileptic or non-epileptic in the moment, is to not overreact, to use calming words. If you know the patient has NES, to talk with them beforehand about, what do you want to be done when you have a non-epileptic seizure in front of me? What's helpful, what's not helpful? Just trying to be responsive to their needs. Because of the trauma, some patients really don't like to be physically touched during their events, for instance. So our clinic is a 6-month group therapy-based clinic. There's only 18 multidisciplinary clinics for functional neurologic disorders across the U.S., and we're the only group therapy-based clinic in the U.S. And I think international too. So the diagnosis gets confirmed by EEG. The patient first sees our neurologist, and the neurologist confirms the diagnosis after the EEG's been done. And then they have an intake with myself or our social worker for behavioral health intake. Then we refer them to groups, and we do 6-week cognitive behavioral therapy group with a multifamily component, and then a 12-week psychodynamic-based group. And then we try to transition them back to community providers. And so referral is, there's just a brief form to fill out. You would send it to our program manager, and that's a simple way to refer to our program. You can always reach out to me if there's questions. And that's it.
Have you experienced patients that have cognitive impairment with this, and how do you address that? Do they have insight into this?
Could you say the name in case?
Sure. For Zoom, the question was, have you experienced patients with cognitive impairment? Yes, and definitely yes. So that cognitive impairment, though, is not always physiologic cognitive impairment, right? So they could have a normal MRI and have had no brain injuries and no reason to have that cognitive impairment. So the two biggest reasons I see it happen are because the patients are dissociating a lot and they're losing chunks of time throughout the day, and so they don't remember anything that was going on during that time. And they can be dissociating outside of their non-epileptic seizures as well. The other thing is actually that is a pretty big group of patients who have functional cognitive decline. And I have a really nice slide from a lecture I went to that kind of defines the different things you look for cognitive versus organic cognitive decline. But that one is really quite tricky because they can work on it, but they feel and subjectively can't remember things. But sometimes there's slight incongruencies or other things that kind of tip you off that it's more functional. But in the cognitive clinic at the U, like in almost every specialty neurology clinic, about 25 to 30% of their patients are functional for any symptom.
Yeah, I would probably.
Yeah, so
agree
it's a
now
lot.
you say
It's
that.
a lot bigger problem than people know.
So for diagnosis, it seems like not that hard to diagnose, to rule it in, the non-epileptic seizures, but then how do you exclude epileptic seizures in that context?
Yeah, good question. So the neurologists have different diagnostic categories. Like when you have a non-epileptic seizure while you're hooked up to a video EEG and have no other abnormal electrical activity in the interictal part, so when you're not having a seizure, they definitively call that NES and are not concerned for epilepsy. Sometimes patients will have abnormal brain activity when they're not having seizures that they see in patients with epilepsy. So then they'll say, working diagnosis or probable diagnosis of epilepsy, but also definitive NES if they've seen the event. And so really, as a behavioral health provider, I really do rely on them, and that's why it's so important for the multidisciplinary component of that's who I go to make sure that we have the right diagnosis before they come to me and get definitive treatment.
In terms of when we're looking for a diagnosis, I imagine that a lot of, I don't know, tell me, can any neurologist do this? Should we be referring to certain places?
So, mostly epileptologists tend to make the diagnosis, but any neurologist, in theory could make it, but the definitive is the video EEG. Sometimes we can't capture people's events, and they've done studies on when you show neurologists versus primary care doctors or psychiatrists a video of someone having a seizure, and they say, is this non-epileptic or epileptic? And primary care doctors get it right about 50% of the time, so it's like a coin flip. Neurologists are really not that much better, right? So the semiology or how it's looking isn't necessarily definitive for what kind of an event it is. So you really do need that video EEG. So sending them to neurology will get them to the right place eventually. But epileptology specifically is the best place for
Okay.
diagnosis.
In Metro, and if you know about Loveland, Pueblo, can you speak to places?
Yeah, so there's Blue Sky Neurology, the university, I'm trying to think where else.
Denver Health.
Denver Health. There's only There's not a lot of epilepsy monitoring units, so where patients go in for 3 to 5 days and are hooked up for all that time to be diagnosed. I think there might only be like 5 across the whole state. And so sometimes it takes patients a while to even get into those. But I can send a list over to James to get to you of different places to send.
The chat is full of gratitude.
Oh,
Thank you. We'll give Dr. Hall the last question.
As a former ER doc,
Mhm.
I have a very unique perspective on this. One of the things we're trained to do is always think worst case scenario. You know, a patient comes in with what looks like to be an epileptic seizure, or is it epileptic or is it non-epileptic? You know, we worry about airway, breathing, circulate. You know, that's what we're trained to do. So from the ER standpoint, I know we want to keep these patients out of the ER.
exactly.
But a lot of these patients, if not the majorities, have these other comorbidities. So how, you know, even when we're taking calls as providers here and doing, you know, this, what's a good tool, what's a good way to kind of differentiate, okay, this is just their NES, or this is something more serious, we do need to worry about this. And we don't want to exacerbate their NES because we're trying to be trauma focused and
Yeah.
worry about that, keep that in mind, but also, is this life threatening? Is this, or do we need, this is just your NES calm down, reassure them.
Mhm.
What's some good tools and advice that you have for us in that aspect?
Yeah, a lot of when we talk to emergency departments, like a lot of these people come to emergency departments a lot, so they'll have on average, I think, 7 ED visits before they get a diagnosis or something like that.
Oh, I would
I was gonna say twice.
Yeah.
That's average. I mean, sometimes patients have such a bad experience that they just on their own figure out, oh, I shouldn't go. And some people just keep trying. So a lot of what we'll counsel EDs to do, especially if you've seen them multiple times, is to put a specific description in their chart. This is what their non-epileptic seizure looks like, so that when they come in and you're talking to them or talking to family members, you say, okay, this is the description we have. Is this what you saw? Is this what you witnessed? Is this what you experienced? And if they did, okay, you can be pretty calm and certain that it's non-epileptic seizure. And if it's different, then it would still put them on a continuous EEG and monitor and try to see. The other helpful thing about putting them on continuous EEG in the ED, if you capture an event and then a neurologist goes to review it, you may have given them a more definitive diagnosis. And a lot of times that won't happen. So.
I just one comment. I know that was the last question. If you even suspect that there's a trauma history or that there's a behavioral or psychological component to anything that your participant is experiencing, bring in your behavioral health provider now that we're moving to integration, and they can really be a support and maybe help uncover some things that you're just kind of suspecting or thinking about.
Thank you so much for your time and for having me. And if you have any questions, James has one.
I don't see her ever, but.
So,